Thank you for coming. And it's my honor today just to facilitate a discussion with really innovations from the front lines, right? Like these are people who are making real changes to real people's lives in the health system, and I think it's a real opportunity for us to learn about how they're making those changes. Innovations are not the first thing in every healthcare provider's mind, and so how do these people manage to do that and then build in the right supports to do so. I am going to, there we go. I'm Walter Wodchis, and we have representatives here from across the spectrum of healthcare, right from telehomecare, virtual care, through to hospitals and primary care. And I think it's a really good, I'm not going to go into the exact details of all of the bios. You do have brief bios, but I will say that we're quite honored to have really the experts and leaders from the province in these areas. Nobody has any commercial interests or potential conflicts of interest, and we've verified that. In terms of the content for this support, please, if you see something interesting, if you hear something interesting, they're really social media savvy or not so social media savvy, think about tweeting at hashtag HQT2014. Really, all of the sessions are focused around learning objectives. Like we're trying to say there's a reason you're going to come to this session instead of another one. And these were the two, I think, that really wanted to make sure is communicated at this session. And they are two. One is to learn about the innovations themselves. So be it an ACE program at Mount Sinai or be it Telehomecare, to think about, what are the innovations that are going on and are they useful in my own practice. And then the second is really a stimulating discussion about the change ideas. So these things don't just happen naturally. And so what are some of the common themes across the program? So each group is going to present, or individual is going to present their innovation in a brief presentation, and then we're going to come back to cross-cutting themes. And that's really going to be the focus of those cross-cutting themes around the population that they're focused on, making connections across healthcare sectors. All of these are focused on being able to cross sectors, cross boundaries, and how did they do that? With case conferencing as an example of some of that. And then enabling technology. So, new age and how is technology helping or not? And then thinking about how do we evaluate, and really these are innovations, but how do we really know the impact, and how can others really be thinking about how to evaluate the impact that they're taking? And we're going to have audience questions, so be thinking about your questions along the way, but we'll group them at the end. So without further ado, I'll introduce Jocelyn Bennett, Senior Director of Quality Performance at Mount Sinai, who's been leading a lot of the innovative work with the ACE.
Thank you for that, and welcome this afternoon. I'd like to acknowledge my co-authors on this work, and I would probably describe them best as co-conspirators on the journey that we've engaged in for now more than 5 years of very intensive work to look at how do we transform an acute care setting in terms of driving elder-friendly care and really looking at system integration. I think when we think about an acute care setting, we were a hospital who about 5 years ago said geriatrics is going to be a core strategic priority. It wasn't a very sexy thing to say at the time. And certainly in coming from an organization like most acute care who value the very high-tech end of what we do, and actually from an organization that's known as the other end of the spectrum with babies, et cetera, this was an interesting priority for us to establish, but it was really based on the ongoing demands of patients within the organization and looking at what the future is going to bring. From this, we really developed an ACE strategy, which was really looking at a comprehensive integrated approach with interprofessional teams working within the organization and cross organizations to look at how do we provide the best care for our patients. And I think really one of the hopefully one of the pieces that you'll take away from today is really the partnerships that we've established both within the hospital, because as much as we work in silos between sectors, we work in silos within hospitals. And so really looking to see how do we create better access to specialist care for vulnerable populations, be it mental health or geriatric medicine, et cetera. But then really collaborating with our home care colleagues to think about providing really a focus around the high-cost, high-needs patients and how do we do something different with them. So our acute care strategy focused on redesigning or looking at sort of sustainable evidence-based approaches, and is there a way to build on our current models of care to really morph and deliver a different kind of work. Really had to get people starting to think a bit differently about the care, and that was everything from certain things need to happen in the hospital, certain things need to happen in the community, to the fact that often what we see in acute care settings is barriers to older adults accessing into care, and that phenomenon that we hear, well, this patient doesn't really belong here. There's nothing acutely ill. Why are they in our emerge? Why are they in our inpatient setting? So starting to think a little bit differently about patient needs, and really starting to think a little bit about risk differently. And this was very important as we started to think about how do we transition patients proactively to the community based on what is, from the acute care setting, a pretty risk-averse background. And really, I think from the beginning, we were very committed to looking at how do we monitor and evaluate and really continuously improve. This is actually probably the most important slide to share with you, and this describes the continuum of care that we've built. And I would say that as an organization, we did identify that there were key areas through which patients and families move. People begin in the community, and ideally our goal is for them to start and return to the community, thinking though about what is the role of an emergency department, both in terms of supporting what occurs in the community, but safely transitioning patients in. And if they don't actually need to come into the hospital, is there a link back that happens between ambulatory or community settings? Really structuring our inpatient side so that we're actually not making things worse. When we think about older adults coming into the hospital, they often present with truly a medical condition or surgical condition which requires hospitalization. But as we move into our very elder-unfriendly environments, we see increased incidences of delirium, decubitus ulcers, UTIs, you name it. And we can take somebody who ought to have a 5-day length of stay, and if we don't manage that stay correctly, we're talking 3 and 4 weeks in hospital if we're lucky. And so really thinking about what were the programs we put in place there, and then what are some of the strategic parts that we need in an ambulatory program to support both inpatient and community. So the kinds of things that I think have been real strengths for us is our emergency department. We have been fortunate to have emerge clinicians there who actually understand that caring for older adults differently makes a difference for them and makes a difference for care in the hospital. They're actually pretty committed to the care that's provided, and we've seen screening and roles there so that they're really trying to early detect. This is our early warning system, and ideally, can patients move back from this? All of those strategies on the inpatient side are focused about really optimizing physical and mental functioning in hospital and really preventing the hazards of hospitalization. A lot of early warning that we do through automatic things like ACE tracker, but very proactive approaches. Select ambulatory so that we can both catch from the emergency department and inpatient side, and then really looking at partners in the community that will help us and help the patients to actually manage for longer periods of time. And some very good success there with our colleagues at CCAC with the ICCP programs, primary care programs, et cetera. The kinds of metrics that we've been tracking over the last 5 years, we've seen a significant increase in the volumes of adults over the age of 65, and that's despite a very consistent admission rate. We admit about 12% of the patients that come to our emergency department, but the volume is continuing to grow in the older adults. We've seen, almost a third off our length of stay. I think a metric we're really proud of is the ability to drive up the percent of patients that actually return home. So they come into hospital and we actually get them home. So in the not going home is convalescent rehab, et cetera. Also done work, quite proud around some of our ALC work. We've actually been fortunate to actually be able to reduce beds based on a number of strategies, but we see the ACE strategy as a key way, despite all the pressures of volumes, to actually be able to conserve resources. And then the patient outcomes that we're really looking at, be it the patient experience or those hazards of hospitalization with ulcers, catheter use, and readmission. So really as we've built this, we have gathered partners along the way through some purposeful work, but we really need to be focused more, we believe, on that better integration with our community. Sometimes it's a challenge because, like many organizations, our patients come from a very broad catchment area, and so getting those partnerships in the right places can be a bit of work. I think the other piece, as we look at the impacts of health system funding reform and volume pressures, is how do we continue to sort of innovate and morph this work going forward. So thank you, and I'll hand over to the next panelist.
Thanks very much. And I always find that inspirational, and I know Samir is also part of this program, inspired me on some of the research because he says, like those shortened lengths of stay, it's a much better outcome for those people. And I've heard him say many times, it's 5% per day, so you can imagine after 20 days in hospital condition these people are in. So getting those down, I think, is an accomplishment for the patients. Next, we're going to hear from Mark and Tori, Mark Pham and Tori Merritt from North York Central, I think really North York General Hospital, where they lead the North York Health Link, and talking about that. And I think that's a real leader in terms of the program here, in terms of both strategic thinking and also project management of actually how do you make this work properly. So Mark and Tori.
Great. Thanks, Walter. So I'll do some of the intro, and Tori will tell you how it was really managed. So I think everyone probably in the room is familiar with HealthLinks now. It was an initiative announced by government a number of years, well, now I guess 2 years ago, 1.5 years ago. And North York was one of the early adopters as the North York Central Health Link, which was really founded on 4 core partners: the hospital, Toronto EMS, the North York Family Health Team, and our central CCAC. And while we have kind of those 4 founding partners, we really do have a large number of community support, community mental health, and other partners at the table, which have really made the HealthLink work. And so I want to recognize really the benefit of everyone's support. So HealthLinks at the end of the day really are about intense care coordination. That is the primary intervention, and it's obviously linking all of the other clinical interventions that have a long history of evidence behind them. And in our model that we designed at North York, we really wrapped that intense care coordination around the medical home concept. So at the core of our Health Link, we have the family physician, the patient, and a care coordinator from the CCAC who act as a 3-person team to look at the patient's goals and needs, obviously bringing any caregivers in who are involved with the patient's care. And then focusing on these 3 dimensions of care coordination, so providing dedicated care coordinators. Within our CCAC, they've actually reorganized completely to organize themselves around the hospital and health link hubs in the central LHIN. And through that, they've given each health link 2 dedicated care coordinators. So they have a reduced care caseload for anyone in the CCAC world in the room who have really been able to focus and work with patients in a much more interactive, dynamic, and intense way. Supporting that is really enhanced care coordination, and that's beyond the care coordinator, of course, to all of the circle of care and others who are outside of the traditional health sense, but involved with that patient's care, that patient's daily activities, and really trying to enable and facilitate communication across the team and across the system. And there's a lot of work spent. I think the care coordinators spend the majority of their day just trying to knit together the different pieces of our system to make it work for our patients. And then at the end of the day, we have a coordinated care plan that is a tool the province certainly drove and felt was important to have as a single document, a single source of truth, if you will, about what are the patient's goals. How do we focus care ultimately around the patient's goals? And as Tori kind of walks through some of our process that we got here, you'll hear the story that, at the end of the day, one of the biggest changes in the innovations, if you will, and it seems strange when we talk about healthcare and patients' goals. You think that was always at the core of it. But actually wrapping around the patient's goals was one of the most fundamental changes in terms of how we organized care, how we coordinated care, and then brought in the health requirements, medical needs, et cetera, for the patient around meeting their individual goals. And I would say the patient and their caregiver as well. So a coordinated care plan has been developed for each of our patients that really helps to organize care, help inform and share information about that patient's goals and their healthcare needs, services, all the different members of their team, and support kind of coordination and communication across the care team. I'm going to pass it on to Tori to tell you a bit more.
All right. And so, as you can imagine, this is a rather intense intervention, and so we want to make sure that we're identifying patients who really need that intervention and can benefit from that. And as I don't know, many people, we've talked a lot about retrospective analysis, looking at high users in a past tense, and what many health links, including ourselves, found was that was very quickly out of date. And so our health link started looking at how do we identify these patients in real time. And we also had a general focus of being trying to look at evidence-based tools that help flag patients that would benefit from these care coordination services. And while no tool is perfect, we were able to leverage quite a few different ones. So just on these slides, it highlights all the different intake sources that we have, and we're actually developing more as we go along. But we started with our inpatient population. We used a tool called LACE, which some hospitals are using, and it basically assesses if a patient's at high risk for readmission to the hospital. And that was our first sort of criteria to help the staff on the floors really focus in on who should they be looking at. And then the other aspects we've actually played with over time. And so we've done various PDSAs to look at. We started with 4 admissions in the last year, and then 3 admissions in the last year, and then 2 in the 6 months, and which comorbidities. So right now, the ones that are listed there are the ones that we're currently going with and seem to be working at this point in time. In Emerge, we haven't actually found a great tool, and happy to chat with people if they have one afterwards. But so far, in conversations with others, I think many of us in the same place. Mental health, it drives many of the Emerge visits, especially amongst our high users. And so as a result, we're focusing on that aspect of our Emerge high users. For primary care, we started looking at a tool that's called the Predictive Repetitive Admission Tool. It was developed out of Johns Hopkins, and it really looks at who's also at risk of readmission, but it's an interesting tool because it's a bit dated and doesn't include many factors that we've heard back from various practitioners around that are still of concern. So it doesn't reflect polypharmacy, it doesn't reflect COPD, those kinds of things. And so we are continuing to evaluate those. And the same with CCAC. We've looked at a tool that they've recently developed based on their RYE tool, but there's been some interesting feedback there too, and so we're continuing to assess those as we go along. And then we just wanted to briefly touch, we've initiated some analysis on whether all this work is having an effect, and so the charts on the left, and I know that you can't read those, but ultimately we've seen a reduction in both ED visits and admissions of patients once they have that coordinated care plan in place. And we specifically only assess patients once they've been in the program for 5 months or longer, just because we felt early days might be a bit too early, plus it doesn't really give them a chance to come back. So we want to be reflective of both sides and sort of position the evaluation from that perspective. And I'll just note that this analysis looked at 2 health links within the Central LHIN because we both have a similar approach, but we wanted to ensure our numbers were a little bit higher, so we joined forces there. And then the other piece is that we have been engaging our patients and providers to also get that qualitative feedback as well, and we're seeing an improvement in terms of patients feeling that their care teams are value what they value or understand what their values are, and that they feel that they're working together better. And primary care providers feel more supported in their ability to manage those complex patients. And out of the different aspects of the model that Mark described, really the case conference, so that joining and being able to connect with the care team was the key piece for primary care providers.
So we have, we're now 1.5 years into our Health Links model, and as Walter described, it's what does it actually take to get it up and started? So if there are kind of later adopters in the room thinking about the elements, these kind of 4 points in this slide speak to both lessons learned as well as areas we need to keep working on as we continue to mature the model. So there are, governance and leadership has been critical for us. Most of us have done, there's as much in-kind contribution and support and leadership goodwill, I think, around the table for all of our partners as there would be funding through the ministry pilot, although both are very important. And it's just the connections and the willingness to work together and to come together that's been so critical in terms of the success we've had so far. Physician engagement has been key. So we've had great leadership from our family physician. We have a very large Department of Family and Community Medicine at North York General of about 300 family docs. And our family health team, who has been instrumental in driving a lot of change, which has been great in terms of really driving physician engagement both within the kind of established structures of family health teams, as well as we reach out into the community to physicians who are on their own, and similarly back into the hospital among our specialist group as well, to make sure we really have everyone around the table. The idea of active partnership can't be understated. It really is about partnership that brings us together. When we talk about coordination, it's all about how do we get everyone around the system with our patients and caregivers working together around this. And I know there's going to be some discussion later about IT. We have put our toe in the water only just slightly in IT. But to Joshua's comments this morning about trying to work beyond our boundaries, we're happy to report we're also going to be working beyond our own boundaries, working with folks in Toronto Central Lynn as well as Central Lynn, as we start to look at what's the next stage of IT enablement to make health things work. Okay, thanks very much.
Thanks very much. So next we're going to hear from Dr. David Dane about a very different model of a health link in a community-based, from a more community-based approach. And again, I think this theme of physician engagement is quite key to bring up. So.
Thanks. I'm going to stand because otherwise I can't see the slides. Thank you, Walter, and everyone for having me. I want to talk about the East Mississauga Health Link and really try to focus on this notion of care conferencing a little bit in a bit more detail. I actually think our models are actually quite closely aligned between North York and East Mississauga, and that's very interesting because prior to about a week ago, we really never had any interaction with each other. So it's interesting that we landed at the same place. So East Mississauga Health Link, we were an early adopter as well. The Lynn approached us one day at the family health team, said, are interested in this new concept, and we said, yeah, we're kind of notionally interested. And then the next day it was announced by the minister that we were a lead organization. But I was drawn to it immediately because I'm quite passionate about this whole question about integration and how is it possible that every one of us in the room pretty much gets paid by the same person and yet we have no integration whatsoever. So I was excited to join and took the lead on behalf of the family health team. And we immediately decided to take a co-led approach between our neighborhood hospital, which is Trillium, and Somerville, our family health team, although the named lead organization is the family health team. It's certainly a model of intensive care coordination. We decided that we would focus particularly on adults and not children based on needs, kind of a high-level needs assessment that was done prior to the launch. And again, focusing on folks who can really benefit from the care coordination. And we were very purposeful about a design methodology that said, wherever the patient finds themselves in the system, they should be able to be identified as complex and receive the care coordination services that a health link can provide. So those of you a little bit newer to the health link concept, you may find certain health links that are very much focused on the hospital or very focused on other parts of the continuum. For us, it was about if a patient finds themselves in front of a provider and that provider identifies them as being of significant complexity, we want them to have an access point into the health link. So at a high level, a very sort of simplified version of our clinical pathway, there's a referral process which is sort of somewhat variable depending on where the patient is identified. If they're in the hospital, we have some automated reports similar to what North York was talking about that can identify potential candidates. We also have our coordinator. I just want to call out Anne Mackay in the crowd there. Just give a wave. There you go. She's very shy. Who does some sort of active case finding as well because of her clinical knowledge of some of the units in the hospital. So that's the hospital access point. The community access point, either family physicians or community service organizations, I think that's an important piece, can also make referrals. They just have a very simple form, and we didn't go with an algorithmic approach in contrast to North York. We simply said complexity is somewhat in the eye of the beholder, and we said these are factors that are associated with complexity. Most of the classic things that you would expect, yes, high utilization was there, but we also wanted to incorporate the social determinants, the housing, the transportation, all those kinds of things that none of the algorithms really captured well. And even if there was a good algorithm, we wouldn't have it documented without that clinician being able to tell us that this person has those factors associated with complexity. So, and then the CCAC would do internal transfers because our model also has dedicated care coordinators from CCAC doing the care coordination, and some of the regular CCAC folks would do an internal transfer to the dedicated HealthLink care coordinator when they felt that, you know what, this needs a higher level of coordination than I'm usually accustomed to providing. So the referrals come in, they get screened to make sure that they're, not, from Timmins, which unfortunately we can't serve, although they have a fantastic HealthLink up there. So some minimal screening to make sure it's appropriate, then they're enrolled. It's an interesting finding that not everybody wants this service, even though they may have consented to it in my office or at the hospital or wherever they may find themselves. There's a significant percentage of folks who think they want it when they're presented with the idea, but when they're actually contacted to move forward, they say no, and that's certainly within their rights, but perhaps we need to do a better job of how we approach them that second time. The model calls for a home visit within a day, and a care conference. We call it a care conference, not a case conference. And I don't think it's just semantics. It's really about the focus about identifying those goals, finalizing the care plan that was developed by the care coordinator on that first home visit. By the way, we target that first home visit to be within a business day. We don't get it, but that's our target. And we try to get a case conference within 7 days with the patient, the family physician, the family, and the care coordinator. So that's trying to get 4 parties together within a week of referral, and it's tough, and we don't always get it. Sometimes we don't even get a care conference at all, but we'll show you the numbers about how successful we are just momentarily. Okay, then we move on to the actual delivery part, and let's talk about some of our results. Just putting up this slide, not for the detail of it, but just to point out that we've been very rigorous that every stage we have a series of data elements that we're collecting, a series of reports quarterly on every single aspect so that we can provide the information back to the system about what was the outcome of this activity. So despite the fact that we don't have a rigorous definition for complexity, we get all the same kinds of things. High LACE score, high comorbidities, social determinants of health, high utilization. So it's interesting that without the algorithm, we still get the right patients, we think. So as I said, we don't always get a care conference. We get it about 60% of the time. 22% of the time we have conversations between care coordinators and physicians, but not a 4-party case conference. And 22% of the time we don't get the primary care provider, and that's a significant percentage that obviously we need to bring down. We get it within about 3 business days, so pretty good, but in terms of the home visit, the case conference, we get it within about 13 days. And if there's that sort of one-to-one conversation, we get that also within 13 days. So we're not yet meeting our goals in terms of the timeliness of the service, but we're constantly innovating and trying to work on that. And we're also trying to listen to patients about, is that actually the right target? Because we set that target. We didn't ask patients, do you want this on that timeline? So we need to go back and re-engage our patients and say, do we have the target right? If so, let's fix the problem. If we don't have the target right, let's recognize that. So does it work or does it not work? Here, these are busy slides, but I want you to focus on the left-hand side, the purple line. That's overall what's happening with average monthly utilization. The sort of dashed lines is what their average monthly utilization was coming into the HealthLink, and you can see over time it drops, I won't say significantly because it's not a statistical analysis, but it drops. And the interesting thing is that for emerged utilization, it drops even further if you get a case conference done than if you don't get a case conference done. And that's an interesting thing. And the other thing that happens if you get a case conference is there's an early rise in utilization, because more often than not, you get referrals when people are in crisis. So they're highly likely to use acute services soon after referral, but that's blunted if you get an early case conference because you get a plan together and hopefully you get a patient who's confident in knowing what they need to do. The other slide is about admissions, and I would say admissions not so much. We certainly have lower admissions rates for people in the HealthLink than their prior level, but we don't see that increased benefit of the care conference, in the case of admissions. And that probably has to do with the process by which somebody gets admitted. It's not generally a patient-controlled event. Somebody has decided that they should be, somebody in the healthcare side has decided they need to be admitted, whereas many emergency visits are directly determined by the patient or family deciding that it's needed. And we've been able to demonstrate that the care conference lowers that more than it lowers the admission rate. So it is making a difference, but it's very hard to get. It is very difficult to get those 4 parties in the same room at the same time. We have a lot of data about what are the reasons that it's hard. Many of them, in fact, not to blame the patient, but it's just the fact that sometimes the patient is not ready or not interested, or if they've been referred from the family doc, they may have just been there that day, so they may not be interested to come back again in less than 7 days. But it is difficult to get those parties in the room. We have used teleconferencing and video conferencing to try to enhance that. And we're trying to bake that into our process a little bit more to decrease those times. We do, as I said before, see reductions in both emerge visits and inpatients, but the case conference seems to have more of a beneficial effect or a preferentially better effect on emerge visits. And we have some early data. We haven't shown it because it is pretty early data, but we have some data that suggests an earlier care conference is more effective than a later care conference overall. So, that's the story. Thank you.
Thanks very much. So definitely learning a lot here. And so next we're going to hear from Lori Poole. I don't know if you noticed, but Lori's Telehomecare was one of the Minister's Honor Roll for the Minister's Rewards this year. So we're going to hear about it now. Thanks very much.
Good afternoon, everyone. It's a real pleasure to be here, and I'm going to spend the next 7 minutes. I only have 7 minutes. I could talk for 7 hours about Telehomecare, but I'll try to squeeze everything in. And Telehomecare in Ontario is a new model of patient care that brings together clinicians and technology to help patients with chronic disease manage their own care in their home. And you may ask, why is this important? This is important because as patients or clients, we spend the majority of time living our lives outside of the healthcare system. So OTN, with its partners, are building a collaborative health coaching and self-management program that is actively involving patients in their own care. So our role at OTN with respect to Telehomecare is to help the healthcare system evolve to better support patients in their homes, in their communities. So what this means at a practical level is that OTN provides project management support. We provide the technology, the clinical leadership, the business process, and the adoption support. But the actual implementation of Telehomecare takes place at the LHIN level. So the LHIN selects a host organization, and that could be a CCAC, a hospital, or a health link. Those organizations employ the Telehomecare team that works with providers and patients across the LHIN to enroll patients into this program. Currently, 7 LHINs in Ontario have Telehomecare programs. The 8th LHIN is currently in planning and will likely go live early next March. And over 4,000 patients have been enrolled in Telehomecare so far. We've been supporting this program for about 2 years, and we have some amazing stories about patients that have really dramatically changed their behavior and improved their quality of life because of Telehomecare. So there are several components to Telehomecare. The most important is the patient, which is at the center of this program. We're currently supporting patients with heart failure, chronic heart failure, or COPD, but as most of you know, these patients have multiple comorbidities. So in terms of eligibility for the program, if they have a diagnosis of CHF or COPD, and they have frequent admissions to the hospital, the ER visit, or to primary care, they're eligible for this program, and anybody, including the patient, can be referred. So once consent is obtained from the patient, a technician will go to the patient's home and install the equipment. It can be installed through a phone line, through the internet, or through cellular connectivity. It consists of a tablet, that is connected to peripherals. So the patient then begins to send in their blood pressure, their weight, their oxygen saturation on a daily basis, and they also answer a number of questions to assess how they're feeling. The patient has a dedicated clinician that monitors their data on a daily basis. But the real gem of this program is the health coaching. So in spite of having heart failure or COPD, the nurse will ask the patient what is important to them. So most patients will say, I want to have more energy or I want to get out more. And that's really how the goal setting is established. The other key component to this program is that the patient and the telehomecare clinician are linked to a most responsible provider. And in the majority of cases, that's a primary care physician, because telehome care is not intended to be a standalone program. It has to be embedded into that patient circle of care. The other value of that primary care physician is that if the patient's condition or symptoms are changing, that clinician can reach out to the provider and explain that, the patient's had a weight gain of 2 pounds, or that, their shortness of breath is increasing. And we've had many situations where the physician was able to intervene and were able to keep that patient at home. So that's the real benefit in terms of supporting these patients. So it really is a circle of care. So our goal is at the program level, our goal is to support, is to focus on a safe and evidence-based telehome care practice that is consistent and standardized across the province. So we've invested heavily in the development of clinical tools and quality indicators, and we work collaboratively with partners across the organization, including RNAO, Health Quality Ontario, the Heart and Stroke Foundation, the Ontario Lung Association, to name just a few. And because we've adopted a patient self-management model, the telehome care clinician will really focus on health coaching and self-management support. So you can see on this slide that the coaching really consists of things that these patients deal with on a daily basis, such as diet, exercising, learning how to manage their anxiety, to name just a few. There's also a care navigation piece that's tied to this program as well, because the actual telehome care intervention is for about 6 months. So after the patient achieves their goals, the intent is to take the equipment out of the patient's home, but we want to make sure that that patient is supported so that they continue to remain in their homes and sustain those healthy behaviors. So we work very closely with a number of community and healthcare providers to ensure that those patients can continue to stay home. In terms of evaluation, there's a robust program evaluation that has taken place at a provincial level. Theta at the University of Toronto is conducting a multi-level framework. They're looking at qualitative and quantitative indicators. They actually have a poster in the exhibit hall that's talking about some of the early qualitative findings that they've uncovered, and they're all very positive. But because we've been up and running for a couple years now, and over 4,000 patients have been enrolled, our LIN partners are working with their host organizations to pull some evidence at the local level. And this is what the providers are really looking at in terms of supporting and adopting this program. So we've seen a significant reduction in ER visits and hospitalizations with those early adopter LINs. So that's really, really important in those early days. But more importantly, we see a very high level of patient satisfaction. And what patients are telling us is that they absolutely love having the technology in their home. It's not a barrier for them to use. The average age of the patient is about 77 years, but we've had patients as old as 90 that have participated in this program. And in terms of the key learnings for the patients, they've told us that learning how to manage their chronic disease and their medications are the most important things that they've learned on telehome care so far. So my last slide is really to talk about the key learnings. This has been a very challenging program to implement, because our healthcare system is not really designed to support patients in their homes and in their communities. So these are kind of some of our key learnings. It's very important to target the right patients. We know that telehome care does not work equally well for all patients, and it's really influenced by by patient characteristics and the state of their disease. We have to make it very easy for providers. Healthcare providers across the province have told us that, yes, telehome care is a good thing. It certainly does no harm for the patient, but they don't have time to look at one more system or one more solution. So we really want to get telehome care embedded, or what we call baked into the healthcare system. So we're spending a lot of time working with hospitals and primary care to get it automatically embedded into best practices and clinical pathways. And I'd also challenge that we as healthcare providers have to change how we think when it comes to supporting patients in their homes with respect to our behaviors and how we think, plan, and manage care for chronic disease patients. And the last key learning is that we have to partner with healthcare organizations and make sure that it's aligned at the system level. We know that there are a lot of competing priorities at the system level, but I think what we've learned in our message today is that, telehome care is innovative, is challenging, and we're probably more than a little disruptive. But I think everybody that is participating in telehome care would agree that it's the right thing to do and that we're heading in the right direction. And as one of our telehome care patients has said to us, that telehome care is a no-brainer. So I'll stop there and look forward to some questions. Thank you.
Thanks. What an excellent note to end on. I was thinking about the minister's comments as I was watching that presentation today, and there's 5 priorities: patient-centered, evidence-based, sustainable, home and community care, and information for consumers. And I think that kind of hit every single one of those. So I think there's a bright future ahead. We're going to have a couple of general questions that I'm going to ask the panel. Different interventions, I think, spoke to these in different ways, and I really appreciate the panelists address these. And then we're going to have questions from the audience. So I mentioned these earlier around selecting patients, evaluation, and other aspects. Just to allow for some of the programs, we had very concise summaries there, but for them to expand on some of these points. So I think the first one I wanted to ask about was around selecting patients, and not only just the approach, which I think we have a little bit of a summary for, but if you could expand on why you chose the approach you took in selecting patients, what it was that you kind of had in your mind in selecting patients, because they all said, and I think it's very important, it's kind of near and dear to my heart actually, that effective interventions need to be given to the right people, right? And that, so sometimes people think, hey, I've got a great initiative, let's just provide it, but not thinking about for whom it will be most effective. So maybe perhaps I'll start down at the end with Lori on this one.
Okay. So we selected heart failure and COPD patients for a number of reasons. They're 2 of the top 5 reasons for hospital admissions and ER visits, not only in Ontario, but across the country. And so we know that they're not being managed very well once they're discharged from the hospital for a variety of reasons. The other thing is that those 2 diseases are quite amenable to this type of intervention. If you look at some of the evidence and some of the other large telehome care programs, particularly the Veterans Health Administration in the U.S. that have enrolled over 90,000 patients in telehome care, they have evidence that telehome care works for this population. Having said that, it's been a bit of a challenge to find these patients. And because there are tens of thousands of them out there, you would think it would be very easy to find them. So that's really been our challenge. And the other thing that we note is that the top 1% of those patients that tend to be end state do not really benefit from this intervention because the model that we've introduced right now is more of a coaching model. So.
Right. Great. I don't know, David?
So I mentioned in brief that we didn't take a scoring-based or algorithmic-based approach, and I just wanted to elaborate very slightly on that. So when we were forming the Health Link, we had a working group who were sort of the data expert type folks, and we wanted to kind of get that sort of integrated view of a patient, looking at the data across the continuum to really understand who the complex patients were in our region. And quite frankly, that resource didn't exist. Each one of us had some idea about what complexity is: primary care, acute care, long-term care, CHCs, whatever. But that integrated view across the continuum didn't exist for us. And so there was no way that even if we had an algorithm, we could actually validate that algorithm. The other reason we didn't go with an algorithm-based approach is that we also know that a lot of people who are complex today actually don't stay complex. if you just look at it from a objective administrative data set kind of point of view, because you'll pick up a lot of folks who are high utilizers currently because of a very severe illness, but that may not be an illness that persists. So the very complex cancer patient who has some complexity related to their treatment and so on, they'll actually register high on whatever method you use for a while, and then they'll drop off. And that's not really who we were thinking about when we were thinking about complexity. So at the end of the day, we really went with an approach that complexity is based on a series of factors that were common across our different viewpoints and that were identified by clinicians in some way, shape, or form. And we could probably open that up further to non-clinicians as well. We just haven't taken that step yet.
Great. And Tori and Mark, you talked about actually changes or some challenges to using a more algorithmic approach.
Yeah, so we started looking at retrospective analysis to really get a sense of the types of patients, and that highlighted the CHF, the COPD, diabetes, mental health, et cetera. And then when we started looking at information that is available in different care settings, so recognizing that primary care does not have the same information that a hospital does, and even ourselves in one hospital does not know that that patient's going to 5 different hospitals down the road, right? So all of those factors. But I would say, I mean, part of the reason was there was just a sentiment amongst all of our participants that were involved with developing this to go down an evidence-based road. But we've always sort of provided that, I don't know if it's an out, but also if your gut really feels that you're really worried about this patient, pick up the phone and call us. Let's have a discussion about it. And we try and use our identification criteria as guides for people. And through our process, we have engaged with all the different sectors to get feedback, and we continue to work with them to get a good sense of, is this getting the right patient for us? Do you feel like we're still missing something here? How do we need to adjust as we go forward?
Do you want to comment and add?
Yeah, I think just with our model being a little bit different, a couple of places. One is that we make the presumption of complexity with patients who filter into us through either our partnership with House Calls or ICCP. But we really do use, from an organizational point of view, the emergency department as a key screener. We do use some standardized tools there that we validated, although I would say that what we continue to hear is that the tools tell you one thing, but a very skilled clinician, based on a thorough assessment and conversation with particularly the patient and the family, however that support is constituted, often will send off some flags for us that we start to look in bringing people in.
Yeah, great. I think those are the really important learnings in terms of having some standardized approach, but allowing clinicians who really understand things that are not being captured in tools. And I know actually on an evidence basis, I looked at 2 integrated care interventions, the GRACE program and the SIPA program, run through an RCT. Both had null findings. In post-hoc analyses, both of them found that they were effective in a higher risk population, but on enrollment, they had trouble first getting the enrollment that they wanted in terms of the numbers of patients, and they just started taking people in. At the end of the day, they have a null finding, right? Because they gave up on really being targeted about the intervention. So I think that's an excellent learning. Here's a real challenge: connecting with other providers. So outside of connecting within your own organizations is one thing, but if you could speak just a little bit to connecting outside your organizations and with whom, and where the real barrier, the most significant barrier that you overcame was, and how you did that. I don't know, Jocelyn, if you want to start on this one.
So I think some of the key partners that we are working with very regularly around both CCAC and also home-based primary care is, I think one of the things that we did early on was we needed to find a way to be able to identify patients really early. What often happens within the acute care setting as patients come in is they may be in hospital for a week to 10 days before somebody actually figures out where they are and what's going on. And so we've actually built, through our electronic health record, We have a database of a registry of patients who are on certain high interventions. And so when they present to the emergency department, there's electronic flags that go out to the team. They go to the team in the emerge as a first warning, and they also go out to other key service providers, either in the hospital or within the community, again, across CCAC house calls in the hospital. And that has probably been one of our key interventions, because that allows us to actually connect 24 hours a day, 7 days a week. And so at least we know and then can start to early intervene.
So one of the first steps that our care coordinators take after they've met with the patient is to reach out to primary care. And that in itself is quite a barrier, I would say, because they have excellent receptionists who are, who are very good at what they do. And so one of the simple solutions that works sometimes, or has helped significantly, it doesn't work all the time, is faxing. We've gone back to this, I don't know, that substandard mechanism, but we do have a standard fax letter that the receptionist can pick and provide to primary care, and that does help us. I would say we get a higher return rate on phone calls from enabling that fax letter. The other piece is if we do have, if one of our care coordinators is really struggling with getting a hold of primary care, they will reach out to me. I will reach out to our chief of family medicine, and they will try to reach out to this doctor as a peer. Half of our health links patients are with family physicians that are not affiliated with the hospital. So there isn't even that I'm your chief relationship there. You're just a pure physician phoning. But that does help many times. And the same thing with specialists. Specialists are hard to get a hold of as well. And even though our patients may come to North York General, their cardiologist may be at Sunnybrook or somewhere downtown, et cetera. And so we use the same route, and our chief of medicine's been very fantastic about reaching out to physicians that he knows or doesn't know but is willing to. And we find often that really helps. And so as much as we try to do broad engagement, engaging family physicians, so expect a call from this, or this is what is going to happen if a patient is enrolled in HealthLinks. Ultimately, I think that helps a little bit, but it's that peer-to-peer connection that's really enabling us to get connected to those people.
Yes, receptionists are very good at what they do. There's no doubt about that. It sounds cliche because we've all said this in some presentation or another before, but, the biggest challenges are the greatest opportunities, right? So collaboration is very difficult. We're actually not built to collaborate. I said in my opening remarks, I'm fascinated about the lack of integration. But it is there, and it's deeply ingrained, and we saw it in the plenary session this morning, and we saw it in all kinds of other sessions that I'm sure that you spoke, that you either spoke at or attended this morning. So collaboration is not very easy, but collaboration is where the wins happen, right? So there's two kinds of collaborations going on in the health links. One level of collaboration is at the patient level. But there's also a collaboration that's going on at the organizational levels to whatever extent these organizations are. So some of them are large and well-defined, and hospitals and CCACs and so on, and some of them are smaller and they're community service agencies, and some of them are primary care, which aren't organized really hardly at all. But let me speak about the organizational one. That is when the power happens, actually. When you actually get all these organizations in the same room solving patient problems, that is when the magic happens, actually, in my estimation. Because it's great to solve the problems one at a time, but with the right organizations and the right commitment in the room at the same time, you actually solve them once, but then they're actually solved for many times. So, for example, we've had some themes that have emerged 2 or 3 times, and we have a care plan development working group that has representation from all our partners, and we look at these cases and we say, oh, you know what, this is the second time food security has come up as an issue. And so although the food bank is not a formal partner in our HealthLink, we bring the food bank person in next time. They explain the whole food bank infrastructure, such as it is in Mississauga, and they educate our care coordinators about the difference between a pantry and a bank and all these kinds of things. And the next time we have a food security challenge, it's actually managed. It's not a new problem to be solved. It's a problem that's been solved once, and it will benefit many. So, collaboration is hard. We all have our own organizational views, and we all have our policies and procedures, and it's very hard for a HealthLink, which isn't actually an organization at all, to change policy and procedure within organizations. But when we actually get the organizations thinking around the patient, things happen, and that's where the benefit comes. So, I don't know.
We agree with everything that's been said so far. Our challenge early on was the host organizations thought that they would be able to easily find these patients. So they looked within their own roster and were able to identify a number of appropriate patients, but we knew that there were many outside of their roster. And so rather than have the nurses do that, because we really want them to focus on the remote monitoring and health coaching, which is what they're really good at, is that the host orgs hired engagement leads. They call them engagement and adoption leads, and they went out there and did a lot of the promotion and did a lot of the education around introducing telehomecare to healthcare providers. And, they've said to us, you just don't go once, you have to keep going back, repeat those visits. So that's really, really important. And you can't underestimate the importance of clinical champions. You need them early, and you need them regularly. And the last thing that we've done is that we're starting to integrate telehomecare referral forms into EMRs. So our vendor owns a bunch, our telehomecare software vendor owns a bunch of EMRs. And so we said to them, here is our referral form embedded into the EMR. So make it very, very simple for providers with respect to the process around getting their patients enrolled.
Great, thank you. And it's interesting. I'm going to skip the case conferencing because I'm conscious of making sure people in the audience have a chance to speak. And also, I'm hearing technology in a number of those responses actually, and those technology support. So I'm going to move on to this, and it also makes me think about technology and like electronic fax in terms of getting out to the primary care, and the wording of these primary care surveys that says, do you use electronic health information in caring for patients? And Canada has like really high response rates to that. Yes, faxes. But the technology aspect, and at varying degrees. I mean, obviously, one platform is entirely technological. But what form of technology is most important to the delivery of the models? If I were to ask that question, I don't know. Do you want to start again, Jocelyn? Or maybe we'll start in the middle this time with Tori and break it up a little bit. People don't know who's going to be called on.
So, interestingly, in our Health Links, we had a choice early on to say how much do we want to make this an IT project and focus on technology, or how much do we want to focus on patients, and we chose patients, which we feel is the right answer at the time. So we actually have done a lot of faxing and paper management, and have not invested a lot of time in technology yet. And that's now one of our Achilles heels that we're now focusing on next. So, if you look at the different components that support the Health Link, yes, Tori's talked about faxing and just traditional faxes and phones. We have through the work at a provincial level from the OACCAC, the CCAC now has that coordinated care plan in an electronic form in their electronic health record, Chris. So that certainly helps some of the users of the document. Of course, it's not necessarily available to everyone in an editable form. So that's a piece that we're still debating on what's next. We are now using some of the OTN services to connect folks in care conferences, and we're not talking care conferences anymore, but so that to make that care conference happen, it's not just everyone has to physically be there present, but it can be phone, can be a video conference. We try to make it as flexible as possible. And then the last piece that we're really starting to explore now, and as a pilot we're hoping to join and start getting involved in, is to enable secure messaging. Because one of the biggest challenges, and the reason why fax is still used, is because amazingly it's secure. And we don't have an easy way to be able to have two clinicians or a clinician and their patient email or text or message each other in a secure way that manages PHI. And so we are now looking at secure messaging platforms to enable that circle of care to coordinate around the patient in real time.
Right.
The next challenge.
Okay, Jocelyn?
So I think we really focused a lot on the use of technology in terms of alerting and screening. Mm-hmm. So I've talked a bit about the alerts that we have for patients that present in our emergency department. We also have an overlay on our electronic patient record. It's called ACE Tracker. And so what it does is it pulls key data elements for all patients over the age of 65 in the hospital. And so you can literally go at a glance to one field in the electronic patient record, and it talks about who the patients are, how old are they, where are they, and then it gives you everything from how are we doing with pain management to the use of high-risk medications, scores around falls risk, ulcer, decubitus ulcer risk, etc. Also pulls out advanced care plans and data elements like that. That's been hugely helpful for us to be able to really at a glance identify who are those high-risk patients that we need to be directing our interventions to. I think the other piece, along with that goes along with the, you know, how do we identify who's at risk, is how do we intervene? And I think we've done this in a couple of different ways. One of our approaches, again, I think based on having an electronic platform, is to be able to, as much as possible in the background, look at how do you make elder-friendly interventions. And so going into order sets and others and simply removing. And, you know, the feeling is that if all of our standardized order sets, which are available electronically, are elder-friendly, whether you're 35 or 85, you're going to get really good care. And so really built that in the background, and so it becomes seamless. We're not asking people to do the right thing, and I think that we saw that earlier today. You can help people to do the right thing, but you can make it really hard to do the wrong thing. And I think that's where the focus has been. I think the other piece where we've really tried to focus is around how do we get that plan of care and have it easily accessible, particularly at those transition points. So, you know, we're starting to do work looking at how do we hand patients off, particularly complex patients. One of the projects that the ED has owned, which actually started as a frequent user project, and it was a care plan project where actually for frequent ED users, care plans were developed and made really easily available. There's a flag that comes up on the registration screen for a frequent user, which then triggers the clinician to go to a standardized plan to look at what's been going on with this person. We started that off again with those who were very heavy users. We identified actually that very complex patients, even if they were less frequent, and I mean when I talk frequency, I'm talking people many times a week, which we see with some of our populations, but really trying to say, how do we put a plan in place for not only for patients who may represent, but if there is a high-risk patient that we're discharging back into the community, having that plan there. So if the patient represents to the emergency department, it's not starting from scratch and saying, oh, well, let's figure out what's going on with this patient, but there's actually a plan that tells you who to call and what are some of the things you need to consider. So really trying to use those kinds of enabling technologies.
David?
Our experience was very similar to North York's. We made a conscious decision up front not to embed a high-tech approach here. We wanted, as one of the early adopters, to get down to the business of designing the model of care first and sorting out, you know, the exact technical requirements and needs later, and had hoped that by the time we got that right, there'd be emerging provincial solutions to support that, and we're a little bit ahead of the provincial solution, so now we have a decision point to make about whether to revisit that question about information technology, because I think there are two areas that really suffer from a lack of a technology solution in our case. One is already been referred to, which is the coordinated care plan is a fantastic exercise to go through. It's very much driven by the patient goals. It gathers all kinds of other information besides their goals in one place. It could be a very powerful, living, organic document for the patient, their family, and the providers. However, in the paper-based form, it doesn't live up to the bill, unfortunately. So it works great for that first week, but after the first week, as things start to happen and medications change and issues arise and other goals come along and so on, it becomes very difficult to continue to share it in real time and in a meaningful way. So we need it for that. I think the other piece would be some assistance with the data analysis. Every quarter when we go about the exercise of really trying to get all the information gathered, there's a lot of manual work done. It takes clinicians and coordinators away from their core activities in order to get the data. And so that's another area where it would be nice if there was some additional assistance. And so we have to get a lot of what the ministry loves to call in-kind resource. That means people doing things for you for free.
At OTN, we spend a lot of time thinking about technology. So, you know, on the patient side, it has to be, you know, cheaper, better, faster. And and we also know that, you know, the device that we're using right now is good. It's a little too expensive, so we constantly push the vendor community on that. But also, we're learning that after the 6-month intervention, that some patients want to continue on the program because they have a chronic disease, and they may not require daily monitoring. Maybe it's weekly, and maybe it's a less frequent coaching sessions. There's still a lot of value in that, and they may have technology in their home that we can support. So those are some of the initiatives that we're looking at. On the provider side, it's all about integration. So, we have a technology team that is working with eHealth Ontario, Ontario MD, to look at how we integrate the centralized telehomecare software so that we can push out meaningful data, to providers and to patients. So that work is ongoing. It's very important.
Great. So the last question I just wanted to ask before we move to the audience, and I'm sure you will have questions, so feel free to actually even start standing at the mic so we know when to cut people off here. Evaluating the interventions. So I've seen a couple of graphs around kind of pre-post and things like this, and I know this is it's a bugaboo of mine too. Like, how do we know in a robust way what works as opposed to good storytelling?
So I can start with a good storytelling. So when we spoke, Tori shared some of our initial data around reductions in emergent visits and admissions, and we are happy to see that we haven't gone the wrong direction for those patients that we've been supporting. The challenge that we have in our data set, and we've kind of shared from the beginning when we share that, we say, but there isn't actually a control group. That's the biggest challenge. From a true robust evaluation, we didn't take a research ethics approach and say we are going to take some, two patient-like patients, say you don't get the intervention, you do. So we really do see a control group, and that's the piece that we're struggling with. The other challenge, if you look at our model, while we kind of showed one slide of here's all the different intake processes, when we actually look at when we started taking our very first patient last July to taking patients today, we slowly opened different doors in terms of different units who could refer right through to the community who could refer. We tried different tools, as Tori shared. We also expanded the comorbidity set. So when we started, it was a smaller set: CHF, COPD, pneumonia, stroke, mental health, UTI. We purposely excluded cancer because, to David's point, cancer patients do go through certainly the acute phase. But we also felt there were a lot more services around those patients at the time we were starting. That door to cancer is now open as well. So if we think about each stage, we've opened the door. So at what point do you set your control group, and how do you create a true control around someone who has CHF, COPD, UTIs, and pneumonia? That's your patient, not just a CHF patient. That's their challenge in robust evaluation.
Right.
Yeah.
Any other commentaries?
So I would agree with those comments about our challenge around evaluation is having that RCT. And we've had many debates, with the ministry and other researchers around that. There is a qualitative and quantitative evaluation going on right now. ISIS is going to be working with Theta to be able to pull data on patients that have gone through telehomecare. Look at their utilization and the quality of their life before the intervention, and compare it after the intervention, but not just look at hospitals and ER visits, look at primary care and long-term care utilization as well. There is more research, really good evidence around telehomecare in the literature today, which is really encouraging. There are so many different models of telehomecare, so it's hard to compare apples to apples. We really believe the model that we've introduced in Ontario around a patient self-management is key. We know that merely introducing technology into the patient's home is not going to change their behavior. So I think when you're looking at evaluation, you really have to look at what the model of care is. So that's important.
Well, and I think just... sorry. Go ahead.
Go ahead.
So, I think within our walls, we've been able to do some evaluation over time of improved outcomes for patients, reduced costs, et cetera. I think the barrier that we have yet to surmount is looking really, given when we look at particularly complex patients, and being able to evaluate them over the trajectory of their care, and how do we really understand whether what we do, it's kind of like the so what. So you do a better job in this particular portion of the care, so what? Does it actually make a difference overall to their healthcare utilization and quality of life? And we don't have those models yet.
So at least every time I speak, I get in trouble for something I say. And now I'm aware now of when I'm going to get myself in trouble. I'm going to get myself in trouble right now with the academics in the room. And I'm going to make the argument that I don't think we need more randomized controlled trials. I have enough problems as a primary care doc trying to translate research on clear RCT stuff. Drug A is better or not better than drug B. Why is that? Because when you do an RCT, you control for all the context, and you take it out, and you isolate exactly the same person, drug A, drug B, which one's better. That is not the activity we're involved in here. We're involved in system redesign, and every single patient here is different, and we need a different evaluative approach, and the gold standard is not a randomized controlled trial.
So I, as an academic, we'll strongly agree with you on that. I do think our methods are behind the times, right? In that we don't have really good, robust evaluative methods, I don't think, to evaluate these programs. I think a couple of things, although it's not really my position to be up here talking and thinking things. I keep saying these things. One is consent-based evaluation. I think about work that's going on at the PATH project around intervention in Northumberland, which is using individual patient consent to link to records so that they can at a later date be linked and at least find some controls from a contemporaneous cohort. Although I'm thinking right now that finding a contemporaneous cohort, you're always looking for the counterfactual. What happened if they didn't get this? And more I'm finding that the people out there who didn't get this got something else. Right? Yeah. At least the complex ones, right? As we chase this problem. So, and I think the RCTs, and I know of a very, intimately a very large trial that was run in Ontario that actually suffered from being locked into an RCT in terms of a standardized approach, and that's what you're trialing. And even though they saw issues coming up and they wanted to make changes to the intervention, they could not because you'd break the trial. And so I think in this world we need better evaluative methods. So on that note, are there other questions from the audience? I'm sure there are a number, but we'll start off and open it up a few minutes. Yes. Please introduce yourself and where you're from, and then ask your question.
Okay, I'm Laura. I'm an occupational therapist at St. Mike's in cardiac and vascular surgery. And I just wanted to know, you guys are doing excellent work, and as far as knowledge translation goes, so you guys have done tons of work. So for other facilities, where do you kind of see that fitting? Is that going to be more CCAC's role, or is it your guys' role, or is it our role to approach you, or what do you see as kind of the best? I know it's a hard question, but because it's great work.
So maybe I can start from a Health Links perspective. From a Health Links perspective, I think there's been a fairly good collaboration community across the different stages of adopters. And I know that, in early days from that knowledge sharing and translation, there was a kind of a lot of ministry support, and now they're kind of getting back into gear around that and how do you create the forums and support around that. So I think this fall, there's going to be 4 or 5 discussions around Health Links, which is great to share. If you even look at our 2 Health Links, we really just connected last week, coincidentally for the first time, and today's point, we came to similar conclusions. So I don't think the models will be so drastically different across the province because they kind of work off the core fundamentals. But right now, I think for the most part, it is just peers reaching out to peers and kind of leaving the door open to chat further.
Different opinions or any to add? No, okay, great. Take a question over here.
My name's Sandra Dalziel. I'm a patient caregiver advocate. For some of you may know, my husband Kevin Leonard passed away July 2015. He had Crohn's disease and in later years comorbidities. So extensive and frequent use of the healthcare system. So very well versed on all aspects of it. And the question that I had, I was interested in this session because of coordinating care. And actually, Jocelyn, you mentioned about representing to the ER. So my question is a sense of, with the work being done, Kevin was one who certainly knew when things were going south. And I'm talking about, we have access to the system, but when you need it in a timely way, when you have a multiple chronic disease, it's go to the ER. That's potentially what needs to happen. And that was actually alluded to this morning as well. I'm talking about the period from regularly scheduled appointments to requiring an ambulance to go to the ER. So I thought with your sessions about the coordinating care, a lot of your work, you're reacting to what is out there. All of your individuals, what do they do if they need to they know something's going south, let's just say.
So a couple things. So one, and I would say we're moving more towards this. So for example, in the coordinated care plan, there are different iterations that are coming about through collaboration and experimentation, use, feedback from the field, et cetera. And so one of the things was that in the coordinated care plan, there wasn't enough of a designated section to say, when I'm experiencing this, what is my first line of defense? Do I need to call someone? Who is it? What's their contact information? And when is it appropriate to go to emerge? So when do the symptoms escalate so much that you should be there? And so that is a discussion that I know our care coordinators have had frequently. I feel like often at the time of crisis, patients are still panicking and still will still go there. And so part of that is to have that conversation a few times to make sure they're comfortable. The other thing that I think you're alluding to is to make sure there is a system to back them up. So is there a physician that can put in an order that needs to happen? We have many patients who have UTIs and they know a UTI is coming, but they can't get the medicine they need without going in a timely fashion without going to emerge. So the other piece that we're looking at is, I don't want to call them medical directives, but having prescriptions in place that will get triggered. And so the care, to call the care coordinator say, yes, I agree with these symptoms, have the physician authorize, okay, release these meds, they're set up to go, and the patient can get them that way. So we're looking at things like that.
No, I think you're pointing the sense of Kevin, we accessed the system. He knew his providers. They knew him inside out. Starting from square one in the ER is just not efficient.
Yes.
And 9 times out of 10, they had to call the specialist anyway. But it's getting access to the providers that know you, that know your case. I mean, Crohn's disease for 40 plus years. And actually, Russell, I put a little plug for you this morning. Russell talked about your one phone number to call for that team. And I just have to say what a relief it is for a patient to get into the system. We access the system, but when you have a chronic disease and you cannot, then the only thing you think, okay, it's 5 a.m., it's okay, let's go to the ER. There's nothing more gut-wrenching than that, to have to make that decision. But once you make the connection, there's a relief. You know something's being done and you're making that contact. And 9 times out of 10, Kevin could have probably done it himself, but but anyway. I just want to have people think about that, please.
Any other comments on this point? Is there? No, okay, great. So we're at time, actually. So I want to just take the opportunity to thank all of our speakers. I think there's a lot of learnings here. Very interesting. Some very similar cross-theme learnings, I think, and I think hopefully you'll all be able to apply them.